हेलो।
हेलो।
हाँ, गुड इवनिंग मैम।
गुड इवनिंग। गुड इवनिंग।
सॉरी मैम, मैं ट्रैफिक में थोड़ा स्टक हो गया था। मैम आप अपना स्क्रीन शेयर कर लीजिए।
हाँ जी, हाँ जी। एक्चुअली मैं फोन कर रही थी ना। इज इट
हेलो।
आ रहा है, दिख रहा है?
यस मैम, यस मैम, आप ना मैम रिकॉर्डिंग स्टार्ट करो, आप स्टार्ट कर दीजिए।
ओके ओके।
ओके मैम।
ओके, गुड इवनिंग एवरीवन। I am Dr. Mukul Pandey, and today we shall be discussing about the oxygen delivery devices in children. Okay, so we all know what is in oxygen. Oxygen is considered as a drug, and it is most probably being used as a most common drug, which is being used in both in pediatric ward, pediatric special monitoring ward, as well as in the PICU. So we, in order to deliver the oxygen, there are certain devices which are being used, and in order to increase the concentration of oxygen in the body when the body itself cannot take care of it, because in the room air we all know that we all breathe at 21% of oxygen, but during the disease time, like in certain cases like pneumonias, bronchiolitis, ARDS, where the ventilation and perfusion mismatch is there, therefore we require a higher amount of oxygen in order to deliver to the all parts of the body. And whenever this oxygen perfusion mismatch is there, body goes into the decreased oxygen supply in the blood, which is called as hypoxemia, and which further goes down to the decreased level in the tissue, which is called as hypoxia. We also know that increasing the FiO2 concentration to more than 0.6, that is about 60%, can cause damage to the body organs because of the generation of the reactive air, reactive oxygen species, which is harmful to the tissues. And also that if the shunt fraction, that is the amount of blood which is not getting oxygenated, that is the VQ mismatch, if it increases more than 30% of the cardiac output, then we need to increase the oxygenation by increasing the fractionated oxygen. So there are certain delivery devices by which we can deliver the oxygen, starting simply from nasal cannulae, then mask, this partial rebreathing mask or the non-rebreathing mask. Then we have ventures. We have a newer oxy mask, and then we move ahead with the certain advanced technologies of delivering oxygen like HFNC, CPAP or BIPAP, and then if that doesn't work, we go to the invasive, that is a mechanical ventilation, and at the last resort, we can completely bypass the function of the lung by providing the child on the ECMO support, where we completely bypass the function of the lung by giving providing the blood, deoxygenated blood, which goes to the artificial lung outside the body, and then it gets oxygenated and ventilated and comes back to the body to deliver to the various part, which is given by the ECMO support. So different delivery systems deliver the different percentage of oxygen at different flow rates. For example, simple mask provides, it's a low flow device, and it gives 40 to 50% at max, 40 to 55% of FiO2 low flow system. Whereas the partial rebreathing and non-rebreathing mask, they deliver the higher percentage of oxygen at high flow system. So partial rebreathing and non-rebreathing are the high flow devices, whereas the simple mask, nasal cannula, they are the low flow devices. What do you mean by high flow and low flow? So if any system, oxygen delivery system, which gives the inspiratory flow, which is capable of giving the inspiratory flows, which meets the oxygen, meets the inspiratory flow demand of the patient, or even exceeds the inspiratory flow demand of the patient, then that system is called the high flow system. In that system, the fixed FiO2s can be provided, whereas in the low flow system is a system where the inspiratory flow demand is lesser than the patient's inspiratory flow demand. So how to calculate these demands? Like normal inspiratory flow demand is normally in children is 3 to 4 times the minute ventilation. So we all know minute ventilation is the tidal volume multiplied by the respiratory rate. So tidal volume is that in pediatric population, this is around 6 to 8 ml per kgs, and the physiological rate we take and then we multiply. For example, if we need to calculate a flow of the 5 kgs child with breathing rate of 50 breaths per minute, so 6 times 5, that is 30, will be the tidal volume multiplied by the 50. So 150 is the 1500 is the minute ventilation of 1.5 liters, and if 3 to 4 times of that will be the normal flow requirement which will be needed, and that is around 4.5 to 7.5 liters per minute. And if any delivery device exceeds or matches this flow, then it becomes the high flow for that patient. We all know that a medical, the oxygen is provided by a medical gas source, either by a wall source system or by the cylinder. In a wall source system, it should be provided at least 50 psi of pressure, whereas cylinders operate at the 1800, a very high psi. Therefore, there is a down regulating valve which is needed to be controlled for the delivery of oxygen pressure. So there is a formula to calculate the amount of FiO2 by nasal cannula. Like, for example, if you're using nasal cannula, then we can calculate that how much percentage of FiO2 will it deliver at low flow system, that is maximum up to 4 to 5 liters. So that is 21%, which is in the room air, plus the flow which is delivered by the nasal cannula can be maximum up to 4 liters multiplied by 3. So 4 times 3, 12 plus 21. So around 34% of oxygen FiO2 can be provided with the nasal cannula. With mask, simple mask is the mask which has a perforations here, which are the exhalation ports, whereas the partial rebreathing mask are the so partial rebreathing mask have additional reservoir that is used for the rebreathing, which is an oxygen enriched gas used for rebreathing. So it has a reservoir in it. It can deliver up to maximum 60% of oxygen. Non-rebreathing mask again has a reservoir, but it has it has a valve at the exhalation port where the exhaled gas rebreathing gas is entrained here. Because of the valve, the outside air doesn't get entered inside and it doesn't get diluted. So at high flow, this non-rebreathing mask can deliver a very high percentage of oxygen, that is 100% it can deliver. Whereas in partial rebreathing, there is no port at the exhalation valve, so the outside air can get diluted, so it can deliver at the max by 60%. Now we have Venturi mask, where it works on a Bernoulli's principle, where the oxygen is delivered attached to this mask, and it has a very narrow orifice which provides a very high flow of oxygen. And based on the different sizes of the orifices, different concentration of oxygen can be delivered, starting from 25% up to maximum it can give up to 60%. So, and there are new devices like oxy mask, which again depends works on the diffuser direct principle, where there is a small hole again which directs the oxygen towards the patients directly to the nose and mouth. And again, different if we increase the flow of the it is a high flow device, so if we increase the flow, we can increase the FiO2 demand of the patient. Okay, and because of the open system, it increases the chance of CO2 rebreathing. Now coming to the another device system that is very commonly used as nowadays, and which is known as a HFNC, that is a heated humidified high flow nasal cannula. It was first started in 1990s in where it was used first time in a race horses, where they used to develop pulmonary hemorrhage following their horse racing, and then it was devised to use in them, and it was found quite effective. And in early 2000s, US FDA approved its use in human species as well. So from horse to horses, HFNC has come, horses to humans, HFNC has come a long way, and it is being most used as a most common high flow delivering devices in present scenarios. As per the definition of HFNC in the neonatal population, defined by the Cochrane review, that as a heated, humidified, and blended air, which is delivered by any nasal cannula, which is able to deliver the flow rate of more than 2 liters per minute, which provides both high concentration of oxygen and potentially provides some amount of continuous descending pressure. That is the definition of HFNC in neonatology population. Any flow which is more than 2 liters, which is able to be deliver more than 2 liters is defined as HFNC for neonate. So components are it's quite simple machine actually. It has a blender which is mixing the air and the oxygen, and we can adjust the knob and we can deliver the FiO2 as per the adjustment of the knob. And then it goes to the humidifier, and then it from humidified and heated gas goes to the heated circuit, and then from it connects to the nasal cannula, and it goes to the nasal cannula mouth nostrils of the patient. So for any device, for whatever device, oxygen delivery device we are using, the mechanism of action or the main purpose or the objective of the using the oxygen delivery device remains the same, that it should decrease the work of breathing of your child. Because once the work of breathing is decreased, then there is automatically there is a reduction in the energy expenditure. For example, we know that if a child is gasping or panting for breath or is breathing very heavily, so what happens is, despite he or she may be able to maintain the SpO2 of more than 94, but in order to maintain that saturation, the child's almost 50% of the cardiac output is being utilized in work of breathing. So eventually what will happen, the perfusion of the body will take a toll over, and the patient will go into respiratory failure. So the whole purpose of giving oxygen support therapy is to decrease the work of breathing, so that cardiac output does not get utilized most often in the work of breathing. Rather, it should be utilized in giving the oxygen delivery or maintaining the perfusion to the vital organs of the body, like brain, liver, and etc. So that should be the whole purpose of using any oxygen delivery devices. And of course, then there are washout of the nasopharyngeal dead space, improving the alveolar ventilation. It provides some amount of distending pressure. The study says that at the very high pressure of around 50 to 60 liters per minute, which is the upper limit being used in an adult population, the HFNC circuit also provides a positive end expiratory pressure of roughly about 5 to 6 centimeters of water. Clinical application in any respiratory patients who is having respiratory distress, then it is used as a weaning mode of after extubation. We apply this HFNC or any non-invasive methods of oxygen delivery devices. And recently, the role of HFNC has come up a long way in using as an adjuvant therapy in using a rapid sequence intubation, where we provide the child with the HFNC cannula. We apply that HFNC cannula, and then we paralyze the child just before putting or inserting an endotracheal tube in the trachea, so that during that paralysis period, the apnea ventilation or some amount of ventilation continues to be goes on, and child does not suffer hypoxemic damage during that period. So it has a good role in RSI, that is a rapid sequence intubation. In transport, it has a role, and in neonatal population, almost every diseases, RDS, TTN, apnea, post extubation, everywhere it has been now used very frequently. Contraindications of any NIV remains the same. If your child is failing, going into respiratory arrest or failure, if your child is not having enough level of consciousness to tolerate that, there is an upper airway obstruction, upper airway anomalies, any hemodynamic instabilities, any already having air leaks, we will avoid these delivery devices. This is the way we choose the size of the cannula, which is very important. We have a chart with the machine with the nasal cannula, and then the point here to note is that almost while choosing the HFNC nasal cannula, almost 50% of this nostril lumen should be occluded only. Remaining 50% should remain patent and should remain open, so as to provide or so as to prevent any air leaks. So this is the way you should choose your correct size nasal cannula. These are the different color codings, which different companies have different colors, so we don't remember by the name. Just see that it can be used in a wide variety, starting from preterms to the pediatric population, and each have their own flow limitation and each have their weight limitation. Please choose according to the maximum weight it can be used up to and maximum flows it can deliver up to. Okay, so this is the way it has to be chosen. How to start it? So we start with, if the child is less than 10 kgs, we start with 2 liters per kg per minute. And if the child is more than 10 kgs, we start with, for every more than 10 kg, we increase 0.5 liter per kg extra or then there is a fixed combination, maximum going up to 50 to 60 liters. So after you have connected the child on HFNC, just see one thing, whether the child's work of breathing is improving or not, which can be calculated by any scores, Downey's score or any score, heart rate, respiratory rate, retractions, SpO2 and all those things. If there is an improvement, you go with the minimum amount of FiO2. So once the improvement is there, then you can, and the disease is under control, then you can start weaning. So don't go by the chart. Just remember one thing, once you start weaning, when the disease is under control, then you first start weaning the FiO2, that is the oxygen level. When it comes down to 40%, then you start tapering down the flows. So first you start with the high flow, 2 liters, and then you come down on flow. Once the flow becomes less than 0.5 to 1 liter per kg, then you switch to from high flow system to low flow system. That is from HFNC to nasal cannula, and then you remove the cannulate altogether. Any HFNC therapy also have some amount of air leaks reported. Practically speaking, I've never seen the air leaks with HFNC, but yes, in very, very preterm kids, they can have with abdominal distension. All these are very common, especially common in the preterm kids who are very small. The advantage is that HFNC responders can be given even breastfeeding, normal NG feeding or OG feeding, and we should not withhold any enteral nutrition to the child who is on HFNC support. We can also give HFNC during HFNC the nebulization support, and actually we should not be giving nebulizer by the mask or the jet nebulizer while the child is on HFNC. Either you remove the HFNC cannula and then nebulize the child, or you can just connect the nebulizer chamber inside the circuit of the HFNC and then nebulize, because of the high flow provided by the HFNC, whatever nebulizer you are giving, that is actually the drug is not nebulized, drug is not going inside if your HFNC cannula is on. So better to connect it to the inspiratory circuit and then deliver it. This is the way it is connected. This is the disinfectant, auto disinfectant circuit of the HFNC, which has a button which, if you connect this red pipe, the machine will auto disinfect on its own. After every use, you have to connect it, and in 55 or 54 minutes, it gets auto disinfected by its own. This is a ROX index which we use, which is defined as the SpO2 upon FiO2 into RR. It just tells us, it just predicts the success or the failure of HFNC. If your index is high after 2 to 12 hours, then it predicts the success. If your score is low at 2 hours, then it predicts the failure. Coming to the another positive airway pressure support, that is a CPAP support, which is very commonly used in pediatric population, especially the neonatal population. It is nothing but just providing the positive pressure to the airways in a spontaneously breathing patients or child throughout their respiratory cycle. That is both during inspiration and expiration. Okay. So effects are many, and they have a very good effects of CPAP on respiratory distress. We have enough evidence to show that it improves the work of breathing, it improves your FRC, it decreases the resistance of the airway, it improves by stenting the airways, and it improves the incidence of apnea, improves the work of breathing, alveolar edema, it improves RDS patients. Lot of studies between now, to the extent that in a very premature babies, they provide CPAP just after the delivery, that is at the in the labor room itself. It improves the FRC so much. So it great role in neonatology. The contraindications again remains the same. Like if your child is having a respiratory failure or arrest, no point giving the non-invasive methods of ventilation. Upper airway anomalies, esophageal fistulas, diaphragmatic hernia, wherever you are suspecting, then the pressure will not be applied and it will be leaked. So then that child is not a candidate for CPAP. Now, most commonly used CPAP system in ICUs is the bubble CPAP, where there is a blender, and this is a blender. This is white pipe is the oxygen pipe which is connected and to the wall source. Then there is a black pipe which is a air source which is again connected to the wall source. Then it mixes in the blender, and there is a knob where FiO2 can be adjusted accordingly, and then it goes to the humidifier, and then the heated humidified circuit goes to the one end goes to the interface, that is the nasal cannula, and the other end goes to this bottle which has a water in it, and it by inserting the amount of rod or the scale, we can actually give the positive end expiratory pressure, that is the positive pressure. So we have discussed the circuit class, interface, and the method of creating a positive pressure. In bubble, it creates with the help of the positive pressure is created with the help of bubble method. Again, different techniques are there as used as an interface, starting from cannulas, which can be used as a mask, nasal mask, nasal prongs, which all these can be used as an interface to deliver the positive airway pressure. These are the different types of mask. We use this Fisher and Paykel mask. It has both mask and nasal cannula, and this is the Hudson cannula. So these are just the different type of interfaces. You don't need to remember this chart, just go by the chart which is being provided by the company's mask we are using. So nasal prongs and the nasal mask most commonly is being used. Both has its own advantages and disadvantages. Nasal prongs is very easily to apply, and it should be snugly fitted, and it provides a better pressure, positive pressure. But the disadvantage is it causes more septal erosion or necrosis, and it causes more abdominal distension. In the one thing to remember that the nasal prongs while using CPAP and versus the nasal prong which we use in HFNC machine, the difference here is that while choosing the size of the nasal prong by CPAP, if you want to deliver CPAP, then the size of the nasal prong should be snugly fitted. There should be no leak, and the mouth also should remain closed. Versus in the HFNC, I've told you that the cannula size to be chosen according to that it should be 50% patent, the nasal nostrils. So this is the difference. I've already discussed this. You connect with the attached with the oxygen and air tubing with blender. Then you connect with the humidifier. Then there is a corrugated heated tube, and then it goes to the inspiratory limb. It goes to the inspiratory part, and the expiratory part is connected to the underwater seal, where by putting the scale of whatever scale we put down in the water, that amount of positive and expiratory pressure is being delivered. Okay, so this is the way it goes. Inspiratory limb and the expiratory part of it. So this is the cannula. It is again a very protective sheath which is being applied to a very preterm infant when we apply CPAP with the nasal prong especially. So it prevents the child baby with the nasal septum necrosis erosion. Certain amount of protection is provided with this protective film. Look at the type of retractions child is having. I hope the audio video is working. See, the child is grunting and having a lot of retractions. So once the child is put on CPAP, now can you just see this mouth is open, wide open mouth is there, and after connecting the child, the child is crying and no air bubble is being provided. That means no PEEP is being provided because the mouth is open, so all the pressure which is being delivered is leaked out. So we have to apply either a chin strap, or we have to close the mouth by using a pacifier or so, or console the child so the child doesn't cry in order to generate the positive pressure. So this has to be kept in mind. Please look for the bubbles, whether it is being generated or not. If it is not, then correct the technique. So see, the mouth is closed, good amount of work of breathing, and then see the bubbles. If you can appreciate the bubble, this is for the same child. We close the mouth and we are able to generate the bubble and see the work of breathing improves. Okay. Okay. So next is how to monitor when we have applied the CPAP. So for the first 4 to 6 hours, we have to monitor every hourly to look for again work of breathing, whether the child has settled down or not after applying the CPAP pressure, whether we need to increase the pressure, is there any leak which is need to be taken care of, is the mouth open, if the bubble is being made or not. So we have to very closely monitor is there any nasal secretion or oral secretion that needs to be sucked out. That also hampers the delivery of the pressure. So this video I've made before and after, Look at the retractions in this child. So much of subcostal, subintra, and sternal retractions. And versus after applying the CPAP, the same child. Look at the comfortably the child is breathing. And this is the amount of comfort the child should be on after you apply the CPAP. Rather, he should be more comfortable after you apply the CPAP than he was before. Okay. We have already discussed the amount of humidification. Complications again remains the same. If you give very high PEEP, so it can develop a pneumothorax. There is a nasal obstruction, nasal septal erosion, gastric distension, which we call it CPAP belly, and then it ultimately can cause the feeding intolerance. Now coming to the non-invasive ventilation, which is BIPAP, which is used in a pediatric population or in a slightly older population. The NIV is again, it all nasal non-invasive ventilation or oxygen delivery devices has a main sole purpose of decreasing the work of breathing, which eventually increase the alveolar gas exchange and improves the ventilation and perfusion. The basic difference between the CPAP and BiPAP is that CPAP provides just the positive pressure at the end of exhalation, that is the PEEP, and over which the patient start breathing, and a constant pressure is applied both during the inspiration as well as during the exhalation. Whereas in BiPAP, we at the constant exhalation pressure, that is the EPAP, patient breathes, triggers the breath and then start inhaling, which is known as the full IPAP. So this way the patient take both inspiratory pressure. Patient takes the breath and then the IPAP pressure is provided, that is the total inspiratory pressure, and then exhalation takes place when that constant EPAP pressure. So exhalation takes place at the same level of EPAP at all the time, and inspiration takes place at the highest IPAP which we provide. We have both negative and positive, but nowadays only non-positive pressure NIV is being used. So it can be used either continuous or intermittent. So the indications, like if you are extubating the child, you want to put the child on NIV, BiPAP, or you can use it as a static mode in milder variety of ARDS, milder variety of asthma, any respiratory support. In a chronic care setting, it also has been used in OSA patient obstructive sleep apnea, any congenital myopathy patient where you need to stent your chest wall with the chest wall compliance issues are there, and etc. can be used. Indications remains the same again to improve the work of breathing. Contraindication again remains the same. If your child is already in respiratory arrest, if your child is unconscious, cannot tolerate, hemodynamically unstable, in a very uncooperative patient, you will not choose this as a method of oxygen delivery device. These are the various interfaces which is being used: full mask, the face mask, and the nasal mask. This is how we choose the size of the nasal mask, and this is how we choose the size of the face mask. It comes in various size, small, medium, and large. Okay. So again, every face mask versus the nasal, the mouth mask and the nasal mask all have their own advantages and disadvantages. Major disadvantage of the face mask is that it causes claustrophobia, but advantage is that it has a lesser air leak. The major advantage of a nasal mask is that it causes disadvantage, it causes air leak sometimes, and then advantage is that it causes less claustrophobia. Patients can eat or drink because the mouth is open. Sorry. So another type of nasal pillow can be used, which is inserted just snugly over the nostrils. It is so small that it can be used even in infants. Like this, we have used this. This is a nasal pillow. See, good. Look at the work of breathing of this child. Quite improved. We just used it after the extubating this child. So quite snugly fitted and is quite comfortable because the mouth is not closed, and so there is no chance of claustrophobia. This is how we choose. This is the mnemonic which is there, how we choose any NIV support therapy. First, you look at the indication and then look at the contraindication as well. If the contraindication is there, please do not use it. Choose the correct equipment with correct size mask, correct size interfaces, with good amount of flows or pressure which you want to generate with that equipment. Use the correct mode and then analyze for failure as well. Analyze for the work of breathing, analyze for the leakage, analyze for any failure factors or monitoring. Okay, so these are various pressure targeted ventilators. You can also give oxygen delivery in the BiPAP. There is an oxygen port which is attached, and you can give certain amount of FiO2 as well. But remember that maximum amount of FiO2 which can be delivered by BiPAP is up to around 50 to 60%, not more than that. Okay. The newer generation BiPAP machine also have humidifiers attached to it, so humidification also is taken care of. Steps I've already explained. You just set the patient, first explain the patient about the utilization of this mask, because if you do not explain the procedure to the patient, he might not tolerate it. First, make the child comfortable, then tell the procedure that you are being applied a mask over your face or over your nostrils, and certain amount of pressure will be given through it, and you have to just keep on breathing normally, and slowly the child will become adaptive to that pressure. So if suppose you want to start with the IPAP inspiratory pressure of 12 and inspiratory pressure of 6, you then slowly increase the IPAP so that child becomes adjusted to it. Okay, make sure there is no leak, and then make sure the child is tolerating and becoming adaptive to it, and work of breathing improves frequently. Monitoring during an IV, again, the main thing you have to monitor is the monitoring of the work of breathing, which includes all your parameters like heart rate, respiratory rate, saturation. For this, we have a score for monitoring, which is a HACOR score, which says heart rate, acidosis, consciousness, oxygenation, and respiratory rate. So these 5 common parameters you want to assess once you put the child on a BiPAP machine. And if it is more than 5, even after 1 hour of application of NIV, then there is an 80% chance that your NIV is not going to work, and you should start thinking that this child might require a higher respiratory support for the oxygen delivery. Okay, so very common parameters. If the scoring is available in this chart, you just calculate the score, and if it is more than 5, you just start think of using another mode. Okay, so this is all, and thank you very much. And if any questions are there, you're most welcome to I'm most welcome to answer that. Thank you so much.
हेलो
हेलो
हाँ जी मैम। मैम क्वेश्चन आंसर में तो किसी ने क्वेश्चन किया नहीं है, तो क्लोज कर सकते हैं आज के सेशन में। थैंक यू सो मच।
ओके,
थैंक यू मैम, गुड नाइट।
गुड नाइट।